Hi, my name is Dr. Bernard Tobo, a consultant urologist at the Urology and Nephrology Center of the Korle Bu Teaching Hospital. I'm here to talk to you about some myths concerning prostate cancer. There are three notable myths among others, and I just want to quickly highlight them. Myth number one, that only old men develop prostate cancer. The truth is that whilst prostate cancer is commoner after 50 years and more common in people who are at high risk, especially among us blacks or those with strong family histories, now we are seeing cases in people who are younger. That is why screening is very, very important. So that myth is debunked. We are seeing younger people developing prostate cancer. To hear about the other myths associated with prostate cancer, join us this Thursday, 25th of September 2025, on our webinar series. And we're going to discuss all the nitty-gritties concerning prostate cancer. All your questions and relevant issues will be discussed. And you'll be glad you are the webinar. See you there.
Hi, so my name is Dr. Kenneth Clufio. I'm a urologist at the Korle Bu Teaching Hospital. As you can see, we're just coming from theater dealing with a case of prostate cancer. September marks Prostate Cancer Awareness Month, where we hope to raise awareness about prostate cancer. Now, prostate cancer is one of the diseases that is killing a lot of men in Ghana. Worldwide, it's the second most commonly diagnosed cancer in men and the fifth leading cause of cancer death in men. And so the burden in terms of the morbidity and mortality is quite high. Who are the people who are at risk? Men. So our brothers, our fathers, our uncles, our sons, we are losing them to prostate cancer. Our bid this month is to raise awareness to make sure that people get tested early and a diagnosis established early so that the morbidity and mortality associated with prostate cancer is minimized. Please remember, early diagnosis of prostate cancer saves lives. So on that note, please meet us this Thursday at our webinar at 4 p.m. where all your questions about prostate cancer will be addressed. We are hoping to see you, and on all this is to help to make sure that we have an early diagnosis of prostate cancer to save lives. Thank you. Hi, so my name is Dr. Kenneth Clufio. I'm a urologist at the Korle Bu Teaching Hospital. As you can see, we're just coming from theater dealing with a case of prostate cancer. September marks Prostate Cancer Awareness Month, where we hope to raise awareness about prostate cancer. Now, prostate cancer is one of the diseases that is killing a lot of men in Ghana. Worldwide, it's the second most commonly diagnosed cancer in men and the fifth leading cause of cancer death in men. And so the burden in terms of the morbidity and mortality is quite high. Who are the people who are at risk? Men. So our brothers, our fathers, our uncles, our sons, we are losing them to prostate cancer. Our bid this month is to raise awareness to make sure that people get tested early and a diagnosis established early so that the morbidity and mortality associated with prostate cancer is minimized. Please remember, early diagnosis of prostate cancer saves lives. So on that note, please meet us this Thursday at our webinar at 4 p.m. where all your questions about prostate cancer will be addressed. We are hoping to see you, and on all this is to help to make sure that we have an early diagnosis of prostate cancer to save lives. Thank you. Hi, so my name is Dr. Kenneth Clufio. I'm a urologist at the Korle Bu Teaching Hospital. As you can see, we're just coming from theater dealing with a case of prostate cancer. September marks Prostate Cancer Awareness Month, where we hope to raise awareness about prostate cancer. Now, prostate cancer is one of the diseases that is killing a lot of men in Ghana. Worldwide, it's the second most commonly diagnosed cancer in men and the fifth leading cause of cancer death in men. And so the burden in terms of the morbidity and mortality is quite high. Who are the people who are at risk? Men. So our brothers, our fathers, our uncles, our sons, we are losing them to prostate cancer. Our bid this month is to raise awareness to make sure that people get tested early and a diagnosis established early so that the morbidity and mortality associated with prostate cancer is minimized. Please remember, early diagnosis of prostate cancer saves lives. So, on that note, please meet us this Thursday at our webinar at 4 p.m., where all your questions about prostate cancer will be addressed. We are hoping to see you, and on all this is to help to make sure that we have an early diagnosis of prostate cancer to save lives. Thank you. Hi, so my name is Dr. Kenneth Klufio. I'm a urologist at the Korle Bu Teaching Hospital. As you can see, we're just coming from theater dealing with a case of prostate cancer. September marks Prostate Cancer Awareness Month, where we hope to raise awareness about prostate cancer. Now, prostate cancer is one of the diseases that is killing a lot of men in Ghana. Worldwide, it's the second most commonly diagnosed cancer in men and the fifth leading cause of cancer death in men. And so the burden in terms of the morbidity and mortality is quite high. Who are the people who are at risk? Men. So our brothers, our fathers, our uncles, our sons, we are losing them to prostate cancer. Our bid this month is to raise awareness to make sure that people get tested early and a diagnosis established early so that the morbidity and mortality associated with prostate cancer is minimized. Please remember, early diagnosis of prostate cancer saves lives. So, on that note, please meet us this Thursday at our webinar at 4 p.m., where all your questions about prostate cancer will be addressed. We are hoping to see you, and on all this is to help to make sure that we have an early diagnosis of prostate cancer to save lives. Thank you. Hi, so my name is Dr. Kenneth Klufio. I'm a urologist at the Korle Bu Teaching Hospital. As you can see, we're just coming from theater dealing with a case of prostate cancer. September marks Prostate Cancer Awareness Month, where we hope to raise awareness about prostate cancer. Now, prostate cancer is one of the diseases that is killing a lot of men in Ghana. Worldwide, it's the second most commonly diagnosed cancer in men and the fifth leading cause of cancer death in men. And so the burden in terms of the morbidity and mortality is quite high. Who are the people who are at risk? Men. So our brothers, our fathers, our uncles, our sons, we are losing them to prostate cancer. Our bid this month is to raise awareness to make sure that people get tested early and a diagnosis established early so that the morbidity and mortality associated with prostate cancer is minimized. Please remember, early diagnosis of prostate cancer saves lives. So, on that note, please meet us this Thursday at our webinar at 4 p.m., where all your questions about prostate cancer will be addressed. We are hoping to see you, and on all this is to help to make sure that we have an early diagnosis of prostate cancer to save lives. Thank you. Hi, so my name is Dr. Kenneth Klufio. I'm a urologist at the Korle Bu Teaching Hospital. As you can see, we're just coming from theater dealing with a case of prostate cancer. September marks Prostate Cancer Awareness Month, where we hope to raise awareness about prostate cancer. Now, prostate cancer is one of the diseases that is killing a lot of men in Ghana. Worldwide, it's the second most commonly diagnosed cancer in men and the fifth leading cause of cancer death in men. And so the burden in terms of the morbidity and mortality is quite high. Who are the people who are at risk? Men. So our brothers, our fathers, our uncles, our sons, we are losing them to prostate cancer. Our bid this month is to raise awareness to make sure that people get tested early and a diagnosis established early so that the morbidity and mortality associated with prostate cancer is minimized. Please remember, early diagnosis of prostate cancer saves lives. So, on that note, please meet us this Thursday at our webinar at 4 p.m., where all your questions about prostate cancer will be addressed. We are hoping to see you, and on all this is to help to make sure that we have an early diagnosis of prostate cancer to save lives. Thank you. Hi, so my name is Dr. Kenneth Klufio. I'm a urologist at the Korle Bu Teaching Hospital. As you can see, we're just coming from theater dealing with a case of prostate cancer. September marks Prostate Cancer Awareness Month, where we hope to raise awareness about prostate cancer. Now, prostate cancer is one of the diseases that is killing a lot of men in Ghana. Worldwide, it's the second most commonly diagnosed cancer in men and the fifth leading cause of cancer death in men. And so the burden in terms of the morbidity and mortality is quite high. Who are the people who are at risk? Men. So our brothers, our fathers, our uncles, our sons.
Good evening, everyone, and and wherever you are watching us from, you are very much welcome to the Korle Bu Webinar Series. Before we go on, I would like us to have an opening prayer from George.
Please, let's pray. Father, we thank you for such a beautiful evening. We thank you that you us to discuss a pertinent issue that would deliver us from other stuff. Lord, we pray that help us and let us have insightful knowledge about prostate cancer. Give our presenters, our doctors, the insight to give us what we need to know about prostate cancer. In Jesus' name, amen.
Thank you very much. And welcome one more time. Today, on the Korle Bu Webinar Series, we're going to have a discussion on prostate cancer. And our theme for the day is Early Diagnosis Saves Lives. Wherever you are joining us from, whether you are a patient or you are a caregiver or you are a healthcare professional, I think you have tuned into a very important session. Today, we have astute gentlemen who are going to lead us in these discussions. We have Dr. Kenneth Klufio. He's a consultant urologist at the Urology and Nephrology Center of Excellence at the Korle Bu Teaching Hospital. He has written extensively and treated prostate cancer and other prostate-related diseases also very extensively. Also, we have Dr. Bernard Togo, who is also a consultant at the Urology and Nephrology Center of Excellence in Korle Bu Teaching Hospital. Bernard Togo has treated prostate cancer patients, numerous prostate cancer patients, has extensively written on prostate cancer. So you know that you are in for a show today. My name is Dr. Isaac Esiedu. I'm also a urologist at the same center. So before, without taking much of your time, we will invite Dr. Kenneth Klufio, who is our main speaker, to give us his presentation on early detection saves lives. Dr. Kenneth Klufio.
Thank you, Dr. Asiedu, for your kind introduction. As Dr. Asiedu has noted, today's discussion is on prostate cancer, with our theme being early detection saves lives. So by way of an outline, we'll have a brief introduction, a discussion on the scale of the problem that we face as men, benefits of early diagnosis, screening, the diagnostic evaluation to establish the diagnosis of prostate cancer, and the treatment options. So to start off with, first of all, we must say that we know a lot of people are unaware of what the prostate gland is. So this is a small walnut-shaped organ that lies underneath the bladder. So the urine flows from the bladder, urinary bladder, through the prostate and then through the urethra to come out. The prostate is also located in front of the rectum, and these are important when it comes to development of prostate cancer and spread of cancer. Now, what is cancer to start off with? When we say somebody has cancer, they have cells in an organ that are dividing and spreading without control or regulation. And so you find that as the prostate is an organ in the body, you can have cells that then lose control and start dividing and spreading throughout the body. And this causes the problems that we face as a result of prostate cancer. What is the scale of the problem that we face with prostate cancer? So according to the Global Cancer Statistics of 2022, where they evaluated the incidence and the mortality associated with prostate cancer, well actually 36 cancers in about 185 countries, they found that they had 10.3 million new cases of cancer being diagnosed in men in 2022. Out of this 10.3 million new cases, prostate cancer accounted for 1.5 million new cases. And so it's a significant burden in terms of the numbers of cases of prostate cancer we are diagnosing on a yearly basis. Also, when it comes to deaths, we found that there were 5.4 million deaths occurring in 2022. And out of this, prostate cancer accounted for about 397,000 deaths only due to prostate cancer, which made it the 5th leading cause of cancer death in men. So there's a high burden in terms of the disease mortality and morbidity. What is the case in Ghana? We have a publication by Prof. Yeboah et al. In 2014, where they assessed about 1,037 men who were randomly screened for prostate cancer. These men aged between 50 to 74. Out of these 1,037 men that were screened, 352 of them were found to have a positive screen, and so further testing was done to see whether they had prostate cancer. 73 out of these men were confirmed to have prostate cancer. So out of the 1,037 men that were screened, 73 men were found to have prostate cancer. If you extrapolate this to the total population of men we have in Ghana, you can have an idea of the burden of the disease that we are dealing with. And so this gives a screen detected prevalence rate of about 7%. There's another study by Prof. Redu et al., where they assessed over a 10-year period the cancer deaths at the autopsy and as well as the death certificate books in all the departments in Korle Bu over a 10-year period. What they found was that prostate cancer was the second leading cause of cancer death in men over the period. So that also lets us know that in Ghana we have a high burden of the disease. Why are we having this emphasis on early diagnosis? So the best way we can look at it is how well these patients with prostate cancer are surviving. Prostate cancer can be confined to your prostate gland, where we describe this as being localized prostate cancer. When it starts invading surrounding tissues around the prostate, we say it is locally advanced. And when this cancer extends to distant sites in the body, your bones, your liver, etc., we say you have metastatic prostate cancer. Now, when we look at the survival rates for those who have cancer only located in the prostate gland which has not spread, we find that 5 years after the diagnosis, almost 100% of them will still be alive. So if we are able to pick up these cases where the cancer is confined only in the prostate, where we have the possibility for a cure, and these patients are treated, most of them will still be alive 5 years down the line, virtually 100%. This is another study that was published by Prof. Mensah et al., where they looked at mortality among patients who had been managed for prostate cancer. So they looked at the records of men who had died from prostate cancer over a 10-year period. When they looked at that record, they found some very interesting findings. One, almost 51% of patients who had died from prostate cancer died within 24 months of the diagnosis. Out of those who had died, most of these were found to be advanced cases, so virtually 80% of them had presented in an advanced stage. When we looked at the 5-year survival for those who had come with cancer that had spread to various parts of the body, only 21% of them were alive 5 years after they had presented with cancer that had spread, prostate cancer that had spread to other sides of the body. And so you can see clearly the difference between those who have been diagnosed early and those who have been diagnosed late with cancer that had spread to the body. And we have to remember, these are men who are dying, families that are being are going to have consequences as a result of the death of their fathers, their uncles, etc., etc. And so every effort must be made to try and identify this disease early. So what are the benefits of early diagnosis? We have a wider range of treatment options if you are diagnosed early. If you come where the disease has spread, we are more limited with what treatment options we can offer you. And so when you come in earlier, it's easier to try and achieve a cure. When you come in late, the best we can do is to try and suppress the disease, but we know at that point we cannot achieve a cure. When you come in early, there are reduced rates of complications. One of our feared complications from prostate cancer is paralysis. Patients come in and are unable to walk because the cancer has spread to their spine. Patients come in and are bleeding from the prostate cancer. Patients come in with kidney failure because the prostate is obstructing urine flow from the kidneys. So all these complications occur in the latter stages of prostate cancer. And so this once again re-emphasizes our intention to try and identify the cases early to intervene to reduce the complications. As we've noted, the survival rate for those who have cancer that is confined in the prostate gland, which is picked up early, most of them will be alive after 5 years of diagnosis. For those who come much later, as shown by evidence of cases that we have seen in Korle Bu, virtually only 21% of them who came in with cancer that had spread were alive 5 years after their diagnosis. Virtually 79% of them had died. Another benefit is peace of mind and better quality of life. When you know you've been screened, you know your PSA is down, the doctor has examined you, there are no problems, so you are more comfortable knowing that you are very unlikely to be having prostate cancer. So what is the aim of our diagnostic evaluation? To try and timeously detect prostate cancer that is clinically significant and leave those that are not significant prostate cancer undetected. You find that there are a number of ways that patients will end up in our care. One of them is that they may come in with clinical symptoms or complaints. Another one is that we are seeing a lot more of now patients are going by themselves to have tests done, a PSA, to find out whether they may have prostate cancer or not. And so depending on their values, they may then come and see us for further evaluation. And screening, which is yet to be formally established in Ghana, is another population-based assessment to see whether patients may have prostate cancer. What are some of the symptoms of prostate cancer? So one, it's important to note, patients will come and tell you, oh, but doc, I'm not having any problems with my urine flow. I don't have any back pain. I don't have any problems. Can I still have prostate cancer? Yes. In the early stages of prostate cancer, most of the cases are asymptomatic. So you may not have any symptoms at all, no problems with the urine flow, no back pain, no problems at all, but you may have cancer in your prostate. And so that is why it's important to screen. The patients may have urinary problems. You may find that they are waking up 4 or 5 times, up to 10 times at night to just go and pass urine. When they go and pass the urine, they have to stand and wait for quite a while before the urine starts to flow. When the urine is flowing, the pressure of the flow is very slow. And then also during the day, they may end up urinating very often or feeling that there's still some urine left in their bladder when they finish urinating. Some patients may have blood in the urine. Others may, as the disease progresses, may come in with weakness in the lower limbs that will then progress to paralysis. Others also have very severe back pain or pain around their pelvis. And others may also develop problems with erection. So these are a few of the symptoms that the patients may present with. What are some of the risk factors for prostate cancer? There are 3 risk factors we cannot do anything about. One is age. So as we grow older, our risk for prostate cancer is higher than that of the younger men. Another one is your family history. If you've had a brother or a father who has had prostate cancer, your risk for prostate cancer is higher than that of the general population. And another one is our race. As Africans, we tend to have a much higher risk for prostate cancer when we compare that to that of the whites or the other races. Those we can do things about our diet. A diet high in red meat, dairy products, etc. Puts us at a higher risk for prostate cancer. Eating a lot more fruits and vegetables, weight loss, tomatoes, etc. also tend to reduce your risk for prostate cancer. And then also, if you're in a family that they have multiple cancers, breast cancer, ovarian cancer, pancreatic cancer, etc. Some of these are due to genetic abnormalities, and so these may put you at a higher risk of prostate cancer compared to the general population. So we'll touch upon screening. When we say we are screening a population, we are looking at a systematic examination of patients who don't have any symptoms, okay? To try and identify individuals who are at risk for developing a certain disease. And this is usually initiated by the health authorities. And the objective of screening is to try and reduce the mortality or death that's associated with the disease and maintain the quality of life for our patients. So what are the pros and cons of screening? When you screen, you are going to be able to pick up the disease early enough, hopefully, to intervene to reduce the mortality rates. We are looking to decrease the number of patients who will come in with advanced disease, because with the screening, you're likely to pick them up earlier in the disease process, and ultimately looking to a reduction of the mortality associated with the disease. We have a few cons of screening, though, we must say, that you may have false positives. You may diagnose patients who have, while they have prostate cancer, it's not the aggressive form, and so these patients may live for long periods with their cancer, but because you are now screening, you pick up a lot of these cancers that may not necessarily be aggressive. And so you find that as urologists, we have some measures that we look at to try and guide us as to whether further evaluation is needed for the patient, that particular patient who is sitting in front of us with their lab report. Overtreatment is subjecting patients who have, while they have cancer, this cancer is not aggressive, but they may be subjected to treatment options that may have some side effects. And they may also have some complications regarding the biopsies and treatment. So generally, when we are screening for prostate cancer, we have two modalities that we use. One is a rectal examination, where we try and assess the prostate to see whether it has features of cancer in it or not. The second modality we use is a blood test. It's called the prostate-specific antigen, or the PSA, which is a common test that we tend to do to give us an idea whether you may have prostate cancer or not. So the best evidence supports the use of the serum PSA, or the prostate-specific antigen, for the early detection of prostate cancer. Using solely the rectal examination is not recommended, and usually should be done in conjunction with the PSA to have the best effect. So on your screens, you see to the left a patient who is having a rectal examination done. You can see a gloved finger has been inserted into the rectum, and the doctor is sort of examining the prostate to see whether it has features of cancer or not. Normally, the prostate should feel firm with well-defined edges and a median sulcus or a groove in the center of the prostate. When we insert our fingers into the rectum, the anus, and then find that the prostate feels hard, or there's induration of the prostate or the seminal vesicles, then the suspicion of prostate cancer arises. When the prostate is asymmetrical in the size and the obliteration of the median sulcus as well, or the rectum is now attached, the prostate gland is no longer mobile over it, all these features may suggest that the patient may have prostate cancer. Usually we'll then proceed to do a test we call the prostate-specific antigen. So this is a blood test. Only a little amount of blood is drawn from the patient. What we are looking for is the PSA, which is a serine protease. That is an enzyme that's produced by the prostate gland. Normally, when a man ejaculates, the emission initially forms a bit of a clot and later liquefies. So the liquefaction of that of the seminal clot is due to the presence of the PSA, and this allows for reduced viscosity for movement of sperm. And you find that the blood levels of the PSA will increase in any condition that is disrupting the architecture of the prostate gland. So what are some of the causes for an elevated PSA? One is prostate cancer. So even though your PSA is elevated, it does not necessarily mean that you have prostate cancer. It means that something is going on in your prostate for which further evaluation is required. Another possible cause of elevation of your PSA may be an inflammation of your prostate gland or an infection of the prostate gland. When you also have an overgrowth of the prostate gland, what we call a benign prostatic hyperplasia, where you have an increase in the size of the prostate gland without the presence of cancer, your PSA may also go up in that instance. If a patient has recently ejaculated prior to doing the PSA, you may find that their PSA may also go up. Or if we have done any instrumentation in the urethra that has involved the prostate, the PSA may also go up. So what we want to let people know is that your PSA that has gone up does not necessarily mean that you have prostate cancer, but further evaluation is warranted to establish whether it is cancer or not. Prostate cancer generally remains a bit contentious in some regions. We have differing results from some studies. There's a prostate, lung, colorectal and ovarian cancer study that was done in the US, which does seem to provide much benefits from having screening done. Other studies have shown that there's some reduction in mortality with prostate cancer. And so generally it's advised that for every patient you should take into account their opinions and desires, as well as their overall health, the family history, and their comorbidities, as to determine whether screening is warranted in that particular patient in front of you or not. So question is, who do we screen? When do we start screening? When should we stop screening? So the European Association of Urology guidelines recommend that for those who have who are more than 50 years of age, they should be screened for prostate cancer. However, if you are an African or there's a family history of prostate cancer from the age of 45, you should start screening. The NCCN guidelines also recommend that from the age of 40, Africans should start screening. And for those who have had multiple cancers in their family, breast cancer, ovarian cancer, pancreatic cancer, etc. Especially if they've undergone genetic testing and they know they have abnormalities of a particular gene called the BRCA, breast cancer gene. Those should start screening also from the age of 40. When do we stop screening? So patients who are older than 75 years generally, or whose life expectancy is less than 10 years. So if you have a patient who has had a stroke, is very unwell, very frail, you would not be looking to do a PSA in such a patient. So patients who are quite fit are those who usually want to do a PSA on. So, but we must say that patients who are even older than this, who are quite fit or vigorous, and who are requesting to have a PSA done, should be appropriately counseled about the risk and benefits of having the PSA screening done. And if it's appropriate for them, we can actually proceed to do the screening. Patients, however, who will not benefit from the testing because they are quite frail and ill, or patients who will not accept treatment if cancer is found, probably should not undergo screening. So generally you find that if you do a single PSA, if the data rectal examination is normal, usually you want to repeat the PSA prior to a decision to follow up on a definitive test to detect whether they have cancer or not. The PSA density is another modality we tend to utilize as urologists to give us an idea of whether we should proceed to do a biopsy or not. The free PSA to the PSA ratio is also another important tool that we utilize as urologists. Another important tool that recently has come up is the use of the MRI prior to the biopsy. And so this is especially, we use it a lot for patients whose PSAs are lying between 3 to 10. So it allows some men to avoid an immediate biopsy, allows us to visualize the prostate gland to see where the cancers may be located, to help us to select the appropriate biopsy technique we utilize. And it's also utilized for patients who are on active surveillance of prostate cancer for low risk to determine when to intervene. So as we said, the EAU guidelines will say that for those who have a PSA between 3 to 10, with a normal data rectal examination, reassess them by repeating the PSA prior to proceeding to further investigations. For those who have a PSA between 3 to 20 and a normal rectal examination, an MRI is also warranted prior to the biopsy in these cases to help to reduce unnecessary biopsies. And for those who have had a family history of having multiple cancers, germline testing where they check on their genetics to see whether they have the genetic mutations is also important. So as we've said, that we will suspect a diagnosis of prostate cancer on the basis of the rectal examination findings and the PSA. However, we can only confirm that you have prostate cancer by taking tissue from your prostate, sending it to the lab and seeing whether there are features of prostate cancer in it or not. So we do that by doing what we call a biopsy. We generally will have two types, a transrectal biopsy and a transperineal biopsy of the prostate. So with a transrectal biopsy, the ultrasound probe is inserted into the rectum. You will see that a needle, we give it some injection so you don't have pain or discomfort during the procedure. The needle is then inserted into the prostate gland and tissue is taken from 12 spots inside of the prostate and sent to the lab to see whether it has features of prostate cancer or not. So the picture to the lower left, the strands of tissue that you are seeing are those that have been extracted from the prostate gland, which will then be sent to the lab to establish whether there's cancer in the prostate gland or not. So this is a patient we did the procedure for. You can see from his back that he's quite comfortable, he's not shouting, not in any pain, he's quite smiling as the procedure progresses. So this is a patient who's having a transrectal ultrasound-guided biopsy of the prostate gland being done here. We can also do a transperineal biopsy of the prostate gland where the needle is not inserted through the rectum, but is inserted in the part of the skin between the scrotum and the anus. The needle goes through that skin directly into the prostate gland. The additional advantages of this procedure is that because it's not going through the rectum, there's a lower incidence of infections. It also allows us to sample the prostates on the anterior surface as well as the apex of the prostate gland. So this picture also shows the transperineal biopsy being done in Korle Bu. There's also a major study that was done evaluating over 7,000 men who had had transrectal biopsies of the prostate done in Ghana. What we found was up to about 48.5% of these patients were found to have prostate cancer, which is almost 50%. We must say that the rates were higher for those who had had a higher PSA and a bit lower for those who had had a lower PSA. But when it was overall averaged, about 48.5% of these patients who had come in either because of an abnormal rectal examination finding or a high PSA were actually found to have prostate cancer. What are a few of the complications that may occur after a biopsy? Most of these complications are self-limiting. You may have a bit of bleeding from the rectum that will usually stop by itself over time. And there are protocols we ensure are put in place before a biopsy is done. We make sure you are not on any coagulants because that can lead to a lot of bleeding, and not any medication that will provoke bleeding as well. An infection or sepsis is another complication that we are worried about, and we have a protocol we utilize with antibiotic prophylaxis to make sure these patients do not develop infections that can be life-threatening. You may also have a bit of blood in the urine or in your semen, and occasionally a bit of problems with erection, but this is usually self-limiting and will resolve. What are the treatment options we have available in Korle Bu? As we said, treatment of prostate cancer is dependent on the extent of spread of the cancer. So treatment when it's limited to your prostate gland is different from when it has started invading tissue around your prostate gland, and it's different from when there's distant spread of the cancer to various parts of the body. So for cancer that is limited to the prostate gland, we have a few options. We can decide, especially for those whose prostate cancer is very low risk by some parameters that we are monitoring, that there's low risk of this cancer to progress. We can decide to monitor them with certain parameters with the intent to treat when there's a change in these parameters. So you may find that they may have repeated rectal examinations, repeated PSAs, and repeated biopsies of their prostate gland. And when there are changes in these parameters, then we treat with the intent to cure. We can also do surgery to completely remove your prostate gland. It's called a radical prostatectomy, and Dr. Tobo is an expert in that area. He's done a lot of that. We also have prostate brachytherapy and external beam radiotherapy that can all be utilized for cancer that is confined to your prostate gland. And sometimes you do combinations of these in the treatment. So this picture basically shows a patient who's had a radical prostatectomy. So you can see that the prostate gland, which has been encircled with dotted lines, is being completely excised. Once that is taken out, the prostate gland the bladder, which is left behind, is connected to the urethra, and this allows the patient to be able to urinate after complete removal of their prostate gland. There are a few complications that can occur. You may find that when we are doing this operation, your main concerns are one, cancer control, making sure the erection is preserved, making sure the patient retains the ability to control the urine flow after the operation. So some of the complications, you may find that after the operation, sometimes there are issues with the erections, and this may occur especially if the cancer is involving the nerves that allow you to get an erection. Or occasionally as well, you may have some problems with a bit of leakage of urine after the operation. So the patient must be thoroughly informed of this prior to the operation. You can also have external beam radiotherapy, where radioactive rays are directed at the prostate gland to kill the cancer that is inside the prostate gland. Another alternative to this is implantation of radioactive seeds into the prostate gland, what is called prostate brachytherapy. And I must say that all of these options are available in Korle Bu Teaching Hospital. So this is a brachytherapy session ongoing in the Korle Bu Teaching Hospital with insertion of the radioactive seeds. And in this image, you can see that the radioactive seeds have been inserted into the prostate gland. For those who have cancer that has begun to spread outside of the prostate gland into surrounding tissue, you may either do surgery where you have a complete removal of your prostate gland or radiotherapy. And usually this is done we add hormonal therapy where we try and modify your hormones. So your male hormone, your male hormone is testosterone. This hormone is known to feed the growth of prostate cancer. So in addition to these other treatment modalities, where you have cancer that's beginning to spread just outside the prostate gland, we utilize that option as well to try and suppress your male hormone, which is feeding the cancer to grow. And then our dreaded stage of prostate cancer is where you have patients who've had cancer that has spread. The cancer has spread to the liver, it has spread to the bone, may have spread to the lungs or other parts of the body. At this point, unfortunately, we cannot achieve a cure. We have possibility of achieving a cure when it's only confined to your prostate gland or when the cancer is just beginning to extend around the prostate gland to surrounding tissues. Once the cancer spreads to distant organs, we know we cannot achieve a cure. But we can try and suppress the disease through various measures. One, unfortunately, because the cancer is feeding on your male hormone, we may have to remove both testes or give you some injections that will prevent your testes from producing what is feeding the cancer growth. At that time, we're also concerned about your pain, or for those who have a catheter in and are unable to urinate by themselves, may do an operation to allow them to urinate without the catheter. These patients very often require blood transfusions and may also require chemotherapy. This study was published by Prof. Che after his training on a scholarship to do a radical prostatectomy. On return, he had quite good outcomes, and so it's important that we are all aware that the skill for a radical prostatectomy is available in country, and Dr. Tobo is another of our surgeons who is highly skilled in doing a radical prostatectomy. This is another study published by Prof. Mensah et al. Regarding prostate brachytherapy in Ghana and the good outcomes that they've had. And since this had been started in Ghana, the treatment results from brachytherapy has been quite encouraging. And so we're encouraging people to almost all these papers are free online and readily available. So in conclusion, as we've seen, we have a high burden of prostate cancer, not just worldwide, but here in Ghana. We are seeing a lot of our patients late, and at the time they come, a lot of them may have had spread of the cancer to various parts of the body. We've seen that for those who come with cancer that's confined to your prostate gland, which usually occurs in the early stages of the disease, most of them will be alive after 5 years. For those who come where the cancer has spread to other parts of the body, from the study that we saw earlier, only 21% of them were alive 5 years after diagnosis. And so this is why we are having this seminar, to let patients know, to let everybody know, please get tested early so that you come in early at a time where we can achieve a cure. Prostate cancer treatments remains a challenge, but efforts are ongoing to ensure that early diagnosis is achieved and reduction in prostate cancer mortality is also achieved. Thank you for your audience.
Easy to understand presentation of prostate cancer. I'm sure for those of us who are watching, you are on the Korle Bu Webinar Series. I must remind you that you can put your questions and any comments at the comment section of any portal that you are watching us from. We will continue the discussion, take your questions, and we'll address all of them as we are on this platform. We're going to go to Dr. Tobo. Dr. Tobo, as I originally introduced him. Is a consultant urologist from the Urology Center of Excellence. Dr. Tobo has treated a lot of patients with prostate cancer and other prostate diseases. So we're going to ask Dr. Tobo to tell us his experiences with some of the patients that he has met and treated, and then we'll take it from there. Dr. Tobo.
Thank you very much. That was a good job, Dr. Klufio. Yeah, Dr. Klufio has managed to give us. He has managed to give us an overview of this prostate cancer conundrum that we found ourselves in. And he has highlighted very, very key points, that there are some factors which you cannot do so much about, but non-modifiable factors. And age is a notable factor. He spoke about the family history and then our genetics. These are things that you may not be able to change. But there are things that at least you can do something about. Your lifestyle, your dietary, plan. And then the key point, early detection, so screening. One of the things that we've realized from this prostate cancer, conditions, once you screen a patient and you detect it very early, you are guaranteed of what? A curative intervention. And he mentioned several of them. I mean, the notable ones, the surgery, then the radiation therapy, the brachytherapy, where you put the seeds into the prostate, and then the external beam. Somebody may ask which one of them, offers you the best intervention. There is no one answer fits all. Depending on the patient's peculiar characteristics and certain factors, one method would, suffice more than others. I specialize in the radical prostatectomy, so I can say I'm biased towards that kind of intervention. And truth be told, patients who come early, you realize that the surgery alone will be able to solve their problems. Now, he talked about certain parameters that we look at to assess, the kind of treatment we'll give you. You realize when the disease is quite aggressive and gone a little, ahead, we have something called Gleason score that we use to check that. Then the surgery alone may not offer you the cure that you require. You may need to combine the various modalities. Either surgery plus the radiation treatment and then some medication. So on a whole, if the patients present early enough, you realize that at least by now, the surgeries that we do, the outcomes are quite good. And contrary to expectation, and that's one of the myths, that when you come and do the surgery, you're going to have a lot of complications. Thankfully, now those complications are, they are to the barest minimum. So we are getting very good outcomes now.
Thank you very much, Dr. Tobo. We will come back to you with many more other questions. I must say that we are privileged and honored to have Mr. Patrick Vignenu here with us. Mr. Patrick has gone through the whole cycle of diagnosis and treatment, and he's here. You can see how happy he is. He's very fit. And so we will ask him to also tell us his story of how he got diagnosed and then how he had gone through the treatment and how he's doing right now. How are you, sir?
Yeah, I'm very good, sir.
All right. So how did you get diagnosed?
I get diagnosed by one Dr. Clothy, because he is my private doctor, so anything at all I went there, he see to me. One day I wake up, I start feeling a back pain. Then I say, oh, because of the kind of work I do, I'm a furniture maker, so we lift things, heavy things and go. So I thought that is what's causing that back pain for me. So usually I don't take a painkiller or what. If I feel pain, maybe I will just lie down flat. For some time I will be okay. But this one, it's not getting better now. So I went to Dr. Clothy. Then I just tell him that, oh, I'm having severe back pain. Then he started giving me some medication, I do some labs. When I took the medication, the thing is more aggressive. The pain is very hard. One day a friend of mine called me and said, oh, why don't you go and do prostate test and see maybe. I said, oh, why not? Then I went to Dr. Prostate to write me a prostate test to go and try and see. He wrote for me, I went there, they did it for me. The next day I should come for the report. As I go there, all of them are just looking at me. Then I asked them, what's the problem? They said, oh, what they did for me yesterday, they didn't get it well, so I have to repeat it again. I said, oh, why? Is it going to be caused by me or? They say, oh, it's free. I say, oh, why not? They should do it. They do the second one. I hope they have the same result. So they give it to me. Then I come back to Dr. Kote. He also see the thing. So my friend, this one is something small. I have a friend at college. So I will let you go and see him. We will solve that problem for you. I say, why not? Just give me a letter, the number of the person as I come. I come meet Professor Che. It took me where he saw the report. He said, oh, no, brother, you have to go and do another one for me. I said, oh, well, if that will be the solution for my problem, then he let me go and do another one at Lance. The next day I went for the reports. I bring the reports, see the reports, I say, the first one I brought was 87 something, but this one was 91. Say, wow. Then he said, oh, my friend, I want you to do A, B, C, D. You are going to do, what is the biopsy. Then there's one called pathology.
Yes.
Okay, so that's the histology.
So I said, Prof, that will be no problem. So they give me a form to fill, then I'll do all those things. Finally, Prof say I have to do, is it a bone scan? Yeah, I thought after bone scan, as you pay, it's easier. Then I went to the place they say, oh, you have to book. I said, well, okay. I booked, they say, oh, maybe 2 weeks time, I can come and do it. Then I went to pay the fee. 2 weeks time, nobody is calling me. Then me myself, I walk to the center, ask them what is going on. Because I'm home, I'm on pay, I'm not taking any medication. So if you people say 2 weeks reach, you are not doing anything, how am I going to survive? They say, oh, I should have a patient. The medicine they are going to use to do the thing, they are going to import it. I say, hey, madam, I'm on pain. I cannot wait more than these 2 weeks. So next week Thursday I should come. Next week Thursday, as I go to Wednesday evening, this lady called me. They say the Thursday cannot come. I say, what do you mean?
Wow. So finally they did the test for you.
Oh, finally they did the test.
Okay, and then following that, what happened?
Following that, when I go home, no, the thing is too much for me. I can't see anything. They rush me to the emergency bag. Then they say, oh no, this one. They do their checks. Then later they say, oh, I have to. After you see my file, they say, oh, you have to go to WOG.
Right.
Then they brought me to WOG. After they brought in Prof C, they say, oh, this is the man, okay. We are going to do a surgery. So maybe Monday or Tuesday we have to do a surgery. I say, oh, Prof, if you promise that this will be mine.
Right.
Survived this, I don't have any problem on that. So the surgery goes successfully, everything goes well.
Right. So at that point, were you having difficulty walking?
Yeah, My left leg is not working well
At that time.
at that time.
Exactly. So that is the thing. So you came in with pain at your back and then weakness in your left leg.
Yeah.
And then after the surgery done, what happened? You were able to walk, the pain stopped.
The pain stopped. I'm working.
And you are walking now.
I'm doing everything I want to do.
Do you still have pain?
No.
Wow.
No
This is
more
fantastic.
Pain. No more pain.
Exactly.
No more pain.
Yeah. So if you're watching us, you are watching the Korle Bu Webinar Series, and today we are discussing prostate cancer. Early detection saves lives. We've listened to a very extensive and interesting presentation from Dr. Kenneth Klufio. Dr. Bernard Tobo is also with us. He has given us a few thoughts from the patients and some of the things that they say. We'll continue with that. And we have Mr. Patrick Vidnu, who has also told us his journey through prostate cancer, the diagnosis, the treatment, and how he's feeling now. He came with severe back pain and then inability or difficulty with walking because of weakness, and now he's all well after the treatment he received. You can also send your questions on all the online portals, and then we'll deal with them now. I want to come to Dr. Klufio. So, at what age should Ghanaian men be worried about prostate cancer?
Okay. So as we said, you have some two contrasting findings from the guidelines, but we'll say from 40 years. From 40 years as African men, because of a higher risk for prostate cancer, from 40 years, please start screening for prostate cancer. Okay. So usually you see the doctor, they'll do a rectal examination as well as a PSA, which is a blood test to see whether you may or may not have prostate cancer. So from 40 years, start screening.
Right. So our catchword today is from 40 years, once you are a man of African descent, get screened. And you can get screened by talking to your doctor. Says walk to any health facility, talk to your doctor about prostate cancer, and they will direct you as to how to get screened done. Dr. Tobo, I'm sure you've encountered a lot of patients who had some myths and then some misconceptions about prostate cancer. Can you share some with us?
Absolutely. When it comes to the myths regarding prostate cancer, sometimes it can make the appreciation of this, the enormity of this problem quite confusing. Especially our brothers on the other side who propagate these homeopathic and herbal medications and want to sway patients away from the established and well-known curative interventions. One of the popular myths is the fact that only old men develop prostate cancer. Yes, I mean, it has been established that age is one of the non-modifiable factors. So as you age, you are more likely to develop prostate cancer. But Dr. Klufio has made a point. We are seeing younger people. We are seeing younger people developing prostate cancer, particularly in our part of the world where we fall among the high-risk group, and then where there's a strong family history. So a brother, a cousin, a father, had it. It doubles your risk of developing it, and they even tend to develop it at a younger age. So yes, even though prostate cancer is a disease of aging, like I said, we are seeing younger people. So I mean, the youngest person I treated was 42 years.
Wow.
Some of my colleagues have treated people who were 35.
Yeah.
So that is one myth that has to be debunked. That is why screening is always important. Another myth is the fact that you need to have symptoms before you know you have prostate cancer. The fact of the matter is early prostate cancer doesn't show with any symptoms. And that's the frightening aspect. The moment you start having symptoms, either it is due to something else, or if it's due to prostate cancer, then the bird has left the cage. So early prostate cancer usually doesn't, show with symptoms. That is why screening, once again, is very important.
Yeah.
One popular myth also is about the PSA. The moment you do the PSA and the level is high, that means you develop prostate cancer. It is not so. Dr. Klufio has made it very, very clear.
Yeah.
There are other reasons why your PSA level, PSA stands for prostate, specific antigen is the main screening tool, the blood test that we use to detect prostate cancer. The mere fact that it is high doesn't mean that you have prostate cancer. In fact, it's a warning sign. So from there, you decide to do your biopsy. And then the last one I'll touch on is the fact that when you come for treatment, you will lose your sexual function, and then you're going to be, you'll be leaking a lot of urine, impotence, and then urinary incontinence. Thankfully, the treatment modalities, particularly if you have to do surgery, has improved all over the years, has improved such that those complications, even though they were there in the past, now they've been reduced to the barest minimum.
Wow.
So people should not be afraid to seek the right treatment.
That is good. People should not be afraid to seek the right treatment. Keep your online questions coming in. We have received a few of them. We're going to deal with some of them. I will go back to Dr. Klufio. Someone asked, so once I do my PSA test, take me through what should I do next, and then how is it going to end?
Okay. So is this with a positive, an elevated PSA?
Yes, an elevated PSA. He went to do a PSA test and was elevated. What should he do next?
Okay. So once your PSA is elevated, your doctor will examine you again. If on the rectal examination, he doesn't find that it's very suspicious, or your PSA is not that high, somewhere between 3 to 10, the doctor may say, oh, let's repeat your PSA after about a month and let's see. If your PSA is still high, then the next step is to do a biopsy of your prostate gland. And then it also depends on how high the PSA is. You may find that this is between 3 to 10. Your doctor may request an MRI for you before. If it is much higher, you come with a PSA of 100, the doctor may proceed to do a biopsy for you right away.
Okay.
Following the biopsy, the report will let us know whether, one, is there cancer or not? How aggressive is this cancer that you have? And then the doctor will then try and do other tests to see whether this cancer is only located in your prostate gland or whether it has spread to your bone, it has spread to other organs. It may go to your liver, lungs, etc. So these other tests are what we call staging tests. So it may be a bone scan, maybe a PSMA PET scan, it may be a whole body diffusion MRI, and all of these are to see whether the cancer is only in your prostate gland or whether it has spread. So this will let us know, so the treatment options thereafter are dependent on whether the cancer is only in your prostate gland, whether it's invading tissue around your prostate, or whether it has spread. And so the doctor will then have a discussion with you about what the options are for that particular stage of the prostate cancer that you may have.
Okay, all right. Thank you very much. I think that really settles that matter. We have a question from the online audience. Somebody wants to know, is there something that causes, is there any particular cause of prostate cancer so that people will just avoid it? If you know that you drink this and then it will cause you prostate cancer, you avoid it. Would you want to take that?
Yes. It's difficult to say. We know there are risk factors. So if as you are growing older, or you have a family history, or you are an African, or you have genetics that and in your family that are predisposing to cancer development. So these are things that you may not be able to do much about. What you can do much about is your diet, obesity, exercise, avoiding smoking, eating a lot more fruits and vegetables, tomatoes, etc. These are generally more protective. But unfortunately, we cannot point to a single thing that you can do that will say that, oh, if you do this, we'll guarantee that you will not have prostate cancer. So there are risks that we know may increase the chances that you may have prostate cancer. And the things that you can do things about are your diet, regular exercise, weight loss, avoiding smoking, and eating a lot more fruits and vegetables, and tomatoes, etc., are more beneficial.
Right, that is very good. I think that even answers another question that someone has sent. Thomas Allen sent a question whether there was any preventive measures that can be taken. I think we have answered that question. Another question came through Dr. Tobo. Someone is asking, these fantastic treatment modalities you've enumerated, are they also available elsewhere apart from in Accra?
So the treatment modalities, let me go over them again. And I want to stress this point. Our competitors, the herbal practitioners or alternative homeopathic people may want to propagate their medications, drugs. The main treatment modalities when it comes to prostate cancer: surgery, radiation treatment, surgery, radiation treatment. Thankfully, we have urologists all over the country. So there are major centers like Accra, like Kumasi, like Tamale, like Ho, like Sunyani, where we have competent urologists. In Accra, we have various centers. At least who can do the radical prostatectomy, and then we have centers where radiation treatment can be done, at least in Accra, and I think Kumasi also. So yes, these interventions are available, and people can rightly go to the right places to get those treatments done.
Thank you very much. There are still some more online questions, and it comes to our favorite question that we always receive anytime we are doing these discussions. Someone wants to know whether we can confirm the correlation between the frequency of sexual intercourse and prostate cancer, whether it prevents or increases your risk. And there are about 5 questions like that from different people.
Yeah.
Dr. Tomo, I think there was this landmark studies from Harvard which talks about 21 ejaculations a month. And scientifically or theoretically, it may seem to be true. I am using the word seem because it has been theorized that the more you ejaculate, you are sort of decongesting your prostate, so that any toxins which are, within can be let out. But when you look at it critically, 21 ejaculations per month, it's not realistic. In fact, I always answer this by saying that you would die trying to, achieve 21 ejaculations per month before the cancer develops. So it is not a one answer fits all. Somebody may decide that he's going to launch onto 21 ejaculations, and hence it's guaranteed that he's not going to develop prostate cancer. What about if the prostate cancer develops after you've done all that? Exactly. So there are so many other interventions. Generally, a healthy lifestyle, and he's mentioned, and you can add, but I will not mention 21. At least do what you can. Don't be a lazy man. Just do what you can as part of your healthy lifestyle. And I'm sure, and then the screening, once again, we're emphasizing it. And I'm sure you should be all right.
Wow. So just do as much as you can, and then go for your screening. Another question that comes, somebody is saying that it looks like some people with a different ethnic group seem to have more incidence of prostate cancer than another. Why is that so, Dr. Kufio?
So when we are looking at ethnic groups, the change in genetics between these groups are important. So we look at the whites compared to Africans, you find that their rates of prostate cancer are lower. The prostate cancer, when they do get it, tends to occur much later in life compared to the blacks. And their cancer may not be as aggressive. And this is due to the difference in the genetics that underlie the various ethnic groups. So basically, it boils down to genetics. That the difference in genetics among the various ethnic groups.
Right, all right. Somebody wants to know, I think this person has read a lot on prostate cancer, and this is Dr. Gilbert Kofi Selome. He's a PhD person, and he's asking whether all levels of prostate cancer treatment are available in Ghana. He says state-of-the-art prostate cancer treatment. And he mentioned that, Dr. Toto, he wants you to answer that question.
I'm sure it's my old tongue. Yes, Solomon, yes, all levels of prostate cancer treatment, at least the one that can achieve cure for you, are available. I mentioned the radical prostatectomy. We have brachytherapy available. We have external beam radiation treatment available. All these are available in Ghana. there are some other novel treatments which I would say are quite experimental, but be as it may, the main ones, the surgery, the radiation treatment, yes, they are available in Ghana. So there's no, I have to stress this, there's no need for you to take tickets and spend a lot of money to go elsewhere. I mean, yesterday somebody called me that I wanted a referral to go to India. They said, maybe
exactly.
Everything is here. So, Mr. Solomon, or Dr. Solomon, all the treatment modalities are available here. You don't have to go to anywhere.
Everything is here.
Everything is here.
All right, everything is here. All the treatment, novel treatments, everything you want to do on prostate cancer is available right here. Dr. Kufio, someone is proposing the use of stem cell treatment for prostate cancer. What can you say about that?
So treatment is done on the basis of evidence.
Right.
So I must say that you won't find that as a mainstay of treatment anywhere in any of the guidelines.
Yeah.
So I think that's as far as I'll say that.
Yeah, exactly.
I think so. I mean, this is not experimental.
Yes.
We have treatment modalities which are proven all over the years. Mm-hmm. So until it has been established in our guidelines, we will not go along that tangent.
Exactly. All right. So whilst we wait for some more questions from our online audience, there are these other talks that I would like us to discuss. What goes into deciding what type of treatment you give to a patient when you finally diagnose that it is a localized prostate cancer? Why would you choose surgery for one and then radiation for the other, Dr. Kufio?
Okay. So one of the important things that goes into deciding is one of them is the patient's age. If you have a 95-year-old with a localized prostate cancer, you may decide to do what we call watchful waiting. At that age, they may pass away from something other than prostate cancer.
Yeah.
You know that 5-year survival is virtually 100%. If on the other hand, you have a 50-year-old who has prostate cancer, which is confined to your prostate gland, who has obstructive symptoms showing that there's an obstruction to the urine flow, then in such a patient, you are considering surgery more as an option, which will deal both with the obstruction to the urine flow as well as the prostate cancer itself. So the patient's age, the patient's comorbidities, and the parameters of their biopsies, and as well as the staging investigation to see how far the cancer has spread, all influence the particular choice of treatment. So a patient who also has comorbidities for which surgery may not be a good option, they benefit more from radiotherapy rather than a surgical option. So these are things that you find that the surgeon will discuss with the patient. And prostate cancer care is individualized. You don't have a one-size-fits-all policy for everybody. So a lot of things go into the decision-making as to whether we are going to do surgery or radiotherapy, or whether we are going to treat at all, depending on your age and comorbidities. So all these things factor into the decision.
So there is several factors come into the decision for the treatment, the choice of treatment for prostate cancer. So somebody is asking how fast after the diagnosis, if it comes as a localized disease, will the disease spread to the other parts of the body? Somebody was trying to take time in coming for treatments. What should the person know?
Yes, so if that is one of the myths about prostate cancer disease, some think that prostate cancer is a slow, growing tumor. So even after diagnosis, they can afford to mark time. Dr. Kufio spoke about Gleason score. Gleason score is a way in which we assess the aggressiveness of the prostate cancer disease. And based on that, we can, and using a lot of other parameters, we can focus and educate the patient, inform the patient about the aggressiveness of the disease, and emphasize on early intervention, because you cannot be diagnosed and then you decide that, hey, let me wait, this thing is not going to spread. Some I must admit, especially the mild diseases based on the Gleason score may grow slowly. But if you have other conditions, other diseases which are of what we call intermediate or high severity, then you may need to give it some form of quick attention so that it doesn't spread to the other parts of the body.
Exactly. So it will depend on the parameters of your disease at the time of diagnosis. And why would you want to make a diagnosis if you don't want to treat it immediately? Why would you want to wait until it goes? This even brings to one example one of our consultants always make concerning a patient he made a diagnosis of. He said that he made a diagnosis and it was a localized disease. Everything was ready for treatment. At that time, some of the treatment modalities were not even available in Ghana, and the patient vanished. He had all the resources to have treatment abroad. Every arrangement had been made, but the patient vanished and appeared 5 years later with back pain, paralysis, and everything. So he asked the patient, "Why did you take all this time before coming?" He said the patient told him that when you were telling me about the disease, you were smiling, so you didn't look serious. So your doctor might be nice to you, but the disease and the diagnosis, serious thing that you must really push to get your treatment as soon as the diagnosis is made. All right.
Let me add to that.
Yes.
As much as possible, you see, a decision of this sort comes with informed consent.
Exactly.
So we will give you all the information as you will need and help you to what?
To make the
help
decision.
you to make a decision.
Exactly.
You know, sometimes because we don't behave like the homeopathic people who have sweet tongue, or sometimes they will do some ceremony around that same treatment. So people don't take us so serious. But I think we all learn a lesson from that example.
Exactly.
We'll stress on the need for people to have a quick and urgent treatment as possible.
Yes, quick and urgent treatment as possible. A question has come in, Dr. Rufio. Person asking, how often should they go and have the PSA test done?
Okay. So you find that the EU guidelines recommend every 2 years. You can actually do it every year, once a year. But usually every 2 years is fine.
All right. So once every year or once every 2 years is acceptable to do. Some even say that if your risk is high, depending on the risk that you have there, you can do maybe twice a year. But once every year seems to be the good norm. If you don't join us, you are still on the Korle Bu Webinar Series on all the social media portals. You can send in your questions and then we have panelists to address the questions. There are a few things that Dr. Tobo, maybe you could address for us. Someone is saying that he heard that once you have the surgery, it is not possible to actually have a sexual intercourse. Can you really throw more light on it?
So when it comes to the surgery called radical prostatectomy, in essence, radical prostatectomy means you are taking all of the prostate. So Dr. Rufio illustrated it. The prostate is sandwiched between the bladder and then the beginning of the penis. So once you take the prostate out, you have to join that part of the bladder to the beginning of the penis. The prostate produces so much of the semen. So after the surgery and you have sex, you're going to experience what we call dry orgasm. So you go to the moon, all right, but it will be dry. You have dry orgasm. What people are scared about is them not having erection at all. And rightly so, because when patients come, we will let you know that these are the possible complications of the condition. But no good doctor worth his salt will go and operate on you and give you complications.
No.
Complications are meant to educate you that these are possibilities, but it doesn't mean that it will occur. One angle that we have to look at this from, you see, when you open up a patient and you are operating, and the best way to assess the disease's condition is when you operate and you are looking at it live. And you realize, sometimes the radiographs or the scans will show you, you realize that the disease has progressed and involved the nerves that will help you with erection. In order to cure the patient, you may have to sacrifice those nerves. And that is where probably the erection may be affected. Other than that, if your disease is well localized and hasn't gone a little beyond, then those nerves can be well protected. And thankfully, you can have your erection. And there are so many of our patients who still maintain their potency, albeit, like I said, the semen doesn't come out as usual because you are taking away the prostate, you are taking away the seminal vesicle.
Great response. Another person is discussing the cost of treatment. Because I think this person has probably read around to see how much this treatment costs. And they are asking whether NHIS is helping with the treatment of prostate cancer. Is there any response from Dr. Kufio?
So I must say, prostate cancer is an expensive disease. There's a lot of effort being made to try and get it on the National Health Insurance. And if you think about it, right from your PSA, the test is not free, it's a bit on the higher side. The biopsy of the prostate that has to be done is also a bit on the higher side. Then the staging investigations, either a whole body MRI, a bone scan, or the PET scan, which is now available in country as well. And then the treatment options, modalities as well, also a bit expensive. So I think if we really want to make an impact, then this has to be, as a country, we must decide the way breast cancer is being sponsored. That it must be on the insurance, national health insurance. The investigations must be paid for. The treatments must be available and must be paid for. Yeah. So it's something that we need to have a wider conversation about and try and get prostate cancer investigation and treatment on the national health insurance.
Yeah, that's great. Dr. We want to add to?
Yes, like you said, prostate cancer treatment is very expensive. I think you will hear from here and there regarding various governments talking about prostate cancer being on the NHIS. We are still waiting for it to see the light of day. But if it happens, it will be good for our citizens. But you see, one thing I've realized, it is better than going elsewhere, because elsewhere it is very expensive. But the other thing I can say, when you educate the patients very well, you let them understand the enormity of the situation, and you counsel them very well, you'll be surprised. Most of them are able to mobilize resources to have their treatment. So yes, it may be on the high side and not be on NHIS, but patient information and counseling helps to, let them organize themselves very well.
Right, okay.
And I must say that we are also looking for support, for sponsorship. Interested companies as well can provide help so that we can provide the services for those who can't afford it. Yeah. We're always open and looking for sponsorship to help with the patient care.
And I know at the center there are times that we actually fund some of the investigations ourselves when we know that we need to have the investigations done and patient genuinely cannot afford it. Another interesting question has come in, Dr. Clufio. Maybe we take this. Someone asking, is prostate cancer sexually transmitted? If somebody has it, can the person give a cancer to the wife?
Yeah. So, fortunately, prostate cancer is not a sexually transmitted disease. So, you cannot transmit prostate cancer to a partner. Okay, so that's
Is it a woman or a man?
The name is not in.
No, because there are some of our patients who, especially the wives, who try to deprive their husbands of sex because of this myth.
Yeah.
And as well, so it's not sexually transmitted. Nobody will give you prostate cancer. Otherwise, it will be the eighth wonder of the world.
Okay. So another question that has come in just now is, can there be a normal PSA level and still patient have a prostate cancer?
Mm-hmm. Yes, definitely. So you find that, especially in the study that was done by Prof. Mensah, where they evaluated over 7,000, Professor itself, over 7,000 patients who had a biopsy done. Some of those with a PSA of less than 4, but who had either a suspicious rectal examination or other tests that had suggested that further evaluation was required. Actually, some of those with a PSA less than 4 were found to have prostate cancer. So you find that when the doctor is evaluating you, they find out about your family history, and the rectal examination is also important. It's also important to note that there are some tumors inside of the prostate gland that don't produce PSA. So if those ones, you may have cancer of the prostate gland, but your PSA will be low. So it's important not just to do your PSA, but have the doctor evaluate you as well with a rectal examination to assess. And yes, it is possible to have cancer with a PSA less than 4.
All right.
So the point of emphasis has to do especially with those with very strong family histories. I mean, there was somebody I saw last week with PSA 2.5. And, as part of the assessments, there's what we call PSA velocity, the rate of rise. And the initial value was 1.3, and then it rose to 2.5. Now, under normal circumstances, this value is normal. But this guy, because the father had it, and he had, uncles who also had it, and he was well educated, so he had an MRI, and it showed suspicious lesions.
Wow.
So that's why it's always good to have somebody qualified, a urologist, attending to your case. Otherwise, you just be walking around 2.5, you are free, 2.5, you are free. You are a walking time bomb.
Yeah. So PSA in itself must be evaluated further. Yeah. So you can have a normal PSA and still probably have prostate cancer. Nuruddin Asina Daniel is asking a question. He says the doctors are saying back pain lead to prostate cancer. It is not so. A back pain can be a sign that there is an advanced prostate cancer. It does not lead to prostate cancer. Mr. Hassan Yasipon is asking whether there is a herbal treatment for prostate cancer. Dr. T.
I'm not the herbalist. But let me stress it, all jokes aside, the established treatment modalities, once again, surgery, radiation treatment, either brachytherapy or external beam radiation. Anybody who tells you he can use herbs to treat prostate cancer, that person is a businessman wanting to make his money and capitalize on people's, naivety. And that is intellectually being dishonest. So herbs don't treat prostate cancer. Exactly. You'll be marking time if you want to use herbs to treat prostate cancer.
Fantastic. So we don't have any evidence anywhere yet. If anybody tells you he has a herbal product that treats prostate cancer, ask him for the scientific evidence to show that and which molecule in that particular herbal treatment that is giving you, and which mechanism of action and the possible complications of that one. Because the drugs and the treatment that we have mentioned, we can tell you the mechanism of action and the possible complications and how to deal with them. If this person doesn't provide any scientific evidence, you must run away from that person who gives you such medications. That's what I would say for now. Dr. Klufio, do you have any other thing that you want to tell the audience as we wrap up?
So I think maybe the focus on the theme. As you've seen in the studies that we discussed, your survival for those who have cancer that is only your prostate gland, virtually 100% are alive after 5 years. Another study that we showed that those who came in with cancer of the prostate that had spread, only about 21% of them were alive after 5 years. And so we shouldn't take things lightly. Please get yourself screened. As Africans, we are at a higher risk for prostate cancer compared to others. So after the age of 40, please get screened regularly to ensure that if you do happen to have prostate cancer, it's picked up early and then appropriate treatment can be instituted.
That's fantastic. Mr. Vijinu, what would you tell other patients who are also having this experience of prostate cancer? What would you tell them?
What I can say is prostate cancer is rare. But if you come for treatment, you can have an answer for your
disease.
For your disease.
Right. Prostate cancer is real. When you come for treatment, you can have the solution and the answer for your disease. Thank you very much. Dr. Tobo, can you have your final words for us?
Well, a take-home message: health is wealth. We should intentionally invest in our health. So everybody, once you are above 40, every year as part of your general medical assessment, you realize that we are stressing on the screening because there are so many things that we can do, the modifiable factors to lower the risk. Healthy eating, exercise, reducing weight, avoiding smoking, adequate sexual intercourse, not 21 ejaculations. So many things you can do, but the bottom line, screening. So as part of our general well-being, every year as part of your medicals, let's include our prostate health. And we want our women to push their men. Very, very important, because when our men are affected, you'll be collaterally what? Affected.
Yeah.
And the thing will not be able to stand, be looking at it, and be complaining. So we should also push our men to seek treatment, and everybody will be happy. Thank you very much.
Thank you very much, Dr. Tobo, and thank you very much, Dr. Klufio and Mr. Vignew. Thank you so much for coming. And our online audience also. This is okay. It's okay. We want to thank you for joining us. Just before we leave, we will take one in-house comment before we leave.
This ambush. Okay.
All right, so that's a message to management for men to have PSA tests once every year. So over to you, management.
Yes, management will take it up.
Management will take it up to do that. Thank you very much. So for those who are able to join us, this has been the Korle Bu Webinar Series, and today we have discussed prostate cancer, and our main theme had been early detection saves life. We started with Klufio giving us an in-depth presentation on prostate cancer from diagnosis to the treatment, and emphasizing that all the treatments are available in Korle Bu. All the treatment. You don't need to travel anywhere to have your treatment. Every treatment is available. We've had someone, Mr. Patrick, who has survived prostate cancer, and now he's free. He's going about his normal duties. Dr. Tobo has extensively educated us on the need to come early for early treatment, and the need not to delay your treatment for your so that we can have the optimum results of treatment. I think it has been an interesting session, and we've all learned a lot from this session. Thank you very much for joining. I'm sure the series will be online. You can go back to it and then look at it again as you wish. You can also share it anywhere else. Thank you so much for joining us. We will sign out for now. Thank you very much. My name is Dr. Isaac Asiedu. Good night.